Welcome back, everybody. Another episode of You Make Me Sick, podcast where started out just as talking about infectious diseases, but obviously we moved on, talking about other illnesses, treatments, and I'm kind of going to send it in a different direction over the next few weeks, months, maybe even just going forward. Just kind of taking a look at kind of healthcare roles, uh, nursing, maybe pharmacy, physicians, other things, see if I can get to agree to come on. But just wanted to thank everybody for listening and kind of being patient. I know I've been off for a while, but glad to be back. So this week, a very, very special guest. It is Nurses Week. If you know a nurse, thank them. It's a tremendous job, hard, stressful, labor intensive, and I'm sure most people appreciate it anyway. But just in case you didn't know, there is 1 week a year. It's in May, usually the first or second full week, and they dedicate that just to recognizing nurses. So in honor of that, my first guest in a while is Allison. Allison is a nursing educator. She works at a level 1 trauma center here in Boston, Massachusetts. She is an educator for an intensive care unit, medical intensive care unit with 26 beds. So she's got her hands full most of the time. Allison, thank you for coming on. I appreciate this. How are you today?
Good. Thank you for having me, Andy, and thank you for having me on Nurses Week.
Yeah, absolutely. And just to provide context, she is my nursing educator. I have been working on the same unit for almost 4 years now. So I've had the pleasure of working with Allison. In my nursing career, I've been at the bedside for 20 years as a nursing assistant and as a nurse. So I've had my share of nursing educators come through the doors. She's by far the finest that I've ever had. That's not to say that I've had others that weren't fine. I've had a lot that have been really great, but she's very hands-on, and I think a lot of that is because she's actually spent a lot of time at the bedside, specifically working in and around that unit as well. So, Allison, thank you for your hard work, and
Thank you.
let's start talking about nursing educators. So, there are certain roles that I don't think people even kind of comprehend that nurses have within a hospital. You and I talked briefly about this the other day. How nurses, especially, or people wanting to get into nursing or go to nursing school, they kind of have this one view of what a nurse is, just being at the bedside, following physician's orders. But there are so many other roles that nurses can do, and I think the nursing educator is one that isn't well known. It's overlooked a lot of the time, and it's probably one of the more important roles because you really are in charge of kind of being the liaison for all new information for education, training updates, everything that nurses who we have continuing education are responsible for. So I guess to get started, like how long have you been a nurse, Allison?
I've been a nurse. July will be 17 years. I'll be a nurse 17 years.
So for a little while then, right?
Yes.
At what point in your career did you decide to actually become a nursing educator?
Well, actually, I was one of those people you were talking about who didn't think of nursing anything beyond the bedside. I grew up in a very traditional house, and my career choices, I feel like that my parents wanted me to go after were teaching and nursing, and that was it. So I wanted to be a teacher my whole entire life. And then shortly before I went to college, my grandfather got sick, and I had a teacher tell me not to become a teacher. She said, it's a thankless job, so don't become a teacher. And I went home and cried. And my mom said, well, now you can go to nursing school. And so I kind of did a whole 180 and went to nursing school, got into the college I wanted to go to, right into the nursing program. And I didn't really give any thought to nursing education. I just thought I was going to be a bedside nurse my whole career. And then probably 2 years into nursing, I wanted to take nursing students. I was like, all right, this seems like something I might like to do. So I took nursing students and I really liked it. So at the 5 year mark, when I was able to, by the state of Massachusetts, I became a clinical educator for nursing students. So I had nursing students at the hospital, one-on-one, but then I went out and had groups of nursing students at the hospital. And I did that and I liked it. And I've actually continued doing that. And now, probably in 2017, I was like, I really like this teaching thing. I wonder if I would like that at the hospital. And at the time, they were looking for people that did clinical teaching to kind of help with the new grad program. And they asked me if I wanted to help. And I said, sure. And it got me out of bedside nursing into the education department as a temporary thing. And then in early 2018, they offered me a full-time position. And that's kind of how I got here. And I haven't looked back.
So I guess a lot of people, they kind of, when you hear, obviously, like you've had the nursing students before you were a nursing educator, it's great that you want to be an educator too. It's almost like combining the two things you want to do into one, which is actually really cool.
Mm-hmm.
Like specifically, if you had to kind of sum it up in a few, not even a few sentences, you can go on for as long as you want, but like specifically, what does a nurse educator do? And do we call them something different? I mean, I've always known it as a nurse educator, but it seems like depending where you go, they may change the name. So like,
Yeah. At Boston Medical Center, we call ourselves nurse educators or nursing professional development specialists. A lot of the other hospitals call them clinical nurse specialists. And really, it's just terminology, and in some cases the degree you have. I have a master's degree but not an advanced practice degree, which means basically I can't give like write prescriptions, and I didn't have to take advanced patho to get a master's degree like someone like a clinical nurse specialist would do. So yeah, I'm called a nurse educator. And I'm sorry, I already forget what the other part of the question was.
Or I was just wondering, like your role, like essentially, like day-to-day role, or even
Mhm.
month to month, like as an educator, like beyond. So you're part of the new. You said with new grads are really important, but also other nurses that come in. Like essentially, when I first started there, I wasn't a new nurse, but I still had because there were certain aspects of the medical intensive care unit that I didn't have on the unit that I came from. Even though I took care of critical care patients, you're responsible for those nurses too. So as a nursing educator, it spans, you're responsible for new grads all the way through experienced nurses, correct? As far as,
Yes.
orientation and beyond.
Yes. So I guess day to day, my job is probably not what you would think. I do have a lot of new grads that I'm kind of training how to be nurses and at the same time training how to be ICU nurses. And a lot of that involves asking them questions and getting them to think about things differently. I like to, like, one of my favorite examples is asking somebody that's been a nurse if they say, the patient coded and got epi 3 times. They can tell me that maybe was like 10 minutes, where a new grad, when they say the same thing, they have no idea what they're talking about. So I spend a lot of time telling them that they can't talk like a real nurse until they're like a grown-up nurse. So I do that with my new grads. And then, like you said, with the experienced staff, I have a lot of people that come from other parts of nursing or come from other ICUs that are just kind of learning the flow of the ICU at my hospital. And so I spend a lot of time with the new hires. That's definitely a huge part of my job. But then a lot of my job is also developing like policies, protocols, educational moments for the staff. Any new product that comes into the hospital kind of gets vetted through the nurse educators. And then we have to make an educational plan for how to get this education rolled out. We also are involved in lots of multidisciplinary meetings. So I meet pretty regularly with pharmacy to talk about different medications, different order sets, anything that needs updated. And I take a lot of the nurses' feedback when I do the policies and when I do talk to pharmacy. I take a lot of that feedback and bring it to the meetings, kind of representing the voice of the nurse at the bedside. And then I meet regularly with doctors kind of to go over, are there any new protocols going on in the ICU that we need to know about? And then on top of that, I also teach classes. So I teach classes pretty much twice a month at least for anybody that's new into the ICU. I also teach classes for various devices that we have in the ICU, and then kind of continuing education classes as well. So
So you,
that's a
so
lot.
it's like everything. Yeah. I mean, that covers essentially just about anything you can or will do, as a nurse. And to that point, so do you know how many nurses that you have? Because it's a 26 bed intensive care unit. So do you know how many nurses you're responsible for off the top of your head? I know it
I'm
changes day to day, but
responsible, it does change day to day. I'm responsible for about 130 nurses and about 15 to 20 nursing assistants.
Oh, so the CNAs are under your purview as well?
Yes.
Oh, I had no idea that you had to do theirs. Jeez, that's crazy. Uh, so with regard, because you were just talking about policies and how they're created, so that's another important role that you have that I think maybe a lot of people don't understand is whenever new policies are introduced, it's usually not just, even though nurses are the ones who'll be implementing them, a lot of them come from pharmacy related, or it's something that is driven by our physicians and their teams and a change that they may want. Uh, we also base all of our practice, medicine in and of itself, it's based on evidence. So this evidence-based data that we have, which is year to year changes. So I can imagine from your point, like you probably, how on top of changes do you have to be? Is this something that you personally have to kind of keep an eye on? Are there changes that come down from above? Because I know there's also, I don't even know, like who's above you, if it's we have like our CNO, like our chief nursing officer, if they end up finding new protocols that they want, like who introduces this to you, or is this something that you have to kind of procure on your own?
Usually a lot of that comes from up above. So the like assistant chief nursing officers, the ones that kind of answer to the chief nursing officer, a lot of it comes from them. Sometimes as the educator, we will find something that's evidence based, but before anything can be done to bring it back to staff, it has to go through all those multidisciplinary meetings. So if someone has a good idea, whether it's a nurse, a pharmacist, a doctor, they tend to bring it to this forum where all of kind of the heads of critical care meet, and we discuss it and see if we think it would be beneficial to bring back to the ICU, and then go from there. That's generally how it works, but a lot of it comes from up above. And then we have to develop an educational plan for everything that rolls out.
When you guys are creating these policies, do you find that the feedback that you give from a nursing perspective, that they take that into consideration, or is it something that, we're going to do this no matter what, you guys need to adhere to it and conform to it? Do you
Um,
find there's much of that, or do you find that it's, relatively well structured with regard to
I
to
think
considering nursing care?
I think it's a good question, because I'm sure the end user, like the staff nurse that's taking care of the patient, gets frustrated with some of the policies that are in place. I'm kind of a nerd for evidence based practice. So when I'm reviewing a policy, I look at different articles and then I go to the textbooks that we use. So in the ICU, we use the AACN, the American Association of Critical Care Nurses. We use their textbook that just got upgraded in November. And actually, we just got the books last week. And so any policies that I have to review, the evidence comes from there primarily. And then we kind of take secondary and tertiary sources into consideration. And then as far as like what's actually going on at the bedside. This is best practice, but what's actually going on at the bedside that we can incorporate into the policy. It can be difficult because policies are very black and white and they don't leave room for interpretation. And in healthcare, there needs to be some gray areas sometimes. So we don't like to make things too black and white where if you don't follow this, you could get in trouble somewhere else down the line. But we try to keep it a little bit gray while following the best evidence that's out there.
So, and I think that you can probably speak to this as, because you've had so much experience at the bedside. Do you feel that that has helped you when kind of helping to kind of mold these policies or put these policies into perspective? Do you feel like having that input, as far as maybe if someone who hasn't had as much experience was trying to do this, might not consider the staff nurse? Do you think that's helped you? Because I can tell you, as a staff nurse, like I appreciate the fact that you're always on top of considering the people who are going to be implementing, all these new policies. So
Oh yes, I think like you mentioned before, I have because I worked in this unit prior to being the nurse educator. I think I have a really good relationship with the nurses. And so I definitely, when I can, take everything that they say into consideration. I think there was a time you and I talked about a policy and I updated it. I don't know if it's gone through yet, but I've updated a policy kind of to allow for some gray area while still having what's best evidence for certain patient populations that we have. But I think a lot of it is knowing your staff and having a good relationship. And if you don't have that, then I think that's when policy people come back and say this policy doesn't work for us, or when there's people that go against the policies. So I think just like having that discussion with the people you're working with is really valuable to helping make the policy.
I agree. So you have a master's degree. You're going for your doctorate right now as well, correct?
Yes.
Is that yeah? So do you need to have a master's degree to become a nursing educator, or is that something that is recommended? Um, and with you, as far as your doctorate goes, how far along are you? Like, are you pretty close to being done?
I have about a year left, which seems like a lot, but I know it will go fast. And all I have left are my project classes. So I've kind of done all the background work, health policy, informatics. I've done all of those base classes. And now the next 6 classes, or my last 6 classes, are all going to be based on my final project, which I haven't really figured out what that is yet. But as an educator, I don't, every place is going to be different, whether you need a master's or not. Most educators I know, whether here or at other hospitals, do have a master's degree. And I think I kind of equate it to, some of the best nurses I've ever worked with are associate degree nurses, and they're the best nurses I've ever worked with. But there's definitely something to say for having a bachelor's degree. I just find that more evidence-based practice gets talked about in bachelor degree programs, and so those nurses have a little bit more insight into why we do things the way we do things and appreciation for it. And I think it's the same with a master's degree. I don't think I am by no means any smarter than anyone else out there, but I think having the master's degree allows me to look at things differently, because the classes I've had to take to get me prepared for this kind of role have allowed me to kind of open my eyes a little bit more to just why things function in healthcare the way they do.
Do you think that to be an educator, that it should be required that you have some kind of a master's degree or something beyond, or do you think that someone who's just experienced and has, I mean, how long had you? I guess the best way to I'm trying to word this is like, should it be required for people to have like an advanced degree to be an educator?
Oh, it's
Just
it's
in your own
tough.
opinion. I mean, it's yeah. Like I'm not trying to put you on the spot here, but
I In my recent experience, I told you before, one of the names of our roles is called Nursing Professional Development Specialist. And that Nursing Professional Development Specialist has to have a master's degree. You can also have a Nursing Professional Development Generalist who kind of works underneath the master's prepared nurse educator. And the master's prepared is kind of delegating things to the generalist. And in my recent experience, I have found that I think people, I think educators should have a master's degree, just because I think there are certain things you learn in master's classes that help you in leadership roles.
and I think that's probably one of the biggest things that I remember when I was getting my bachelor's degree, because I started as an associate's nurse and I took a bridge program. And I think I took more than one course that was just kind of about there was the management aspects, and then also, like you mentioned before, just kind of having more of appreciation for research and then evidence based. And it's because with associate's degrees are great. Some of the best nurses I worked with are certificate nurses, which weren't even associate's nurses. This is something they gave out 25, 30 years ago, and they were fantastic. But they kind of it's one of those things that as nursing has evolved as a profession, excuse me, it's been more driven by data. The having a bachelor's degree and a master's, I'm sure, is probably very helpful, and especially when you're educating other people, it's probably great just to have that to fall back on as far as references and whatnot. So,
Yeah,
um,
and even when you mention though that nursing is a profession, 100 years ago, no one thought of nursing as a profession, and it's evolved into a profession. And I think to be a professional sometimes takes a little bit more. Um, I don't know. I mean, definitely experience, but I think having the degree helps.
Absolutely. All right, moving on. Wanted to ask you kind of as far as so. COVID came in and hospitals got a lot of funding for COVID, and then the funding just stopped, and a lot of hospitals had to cut budgets. Even here in Boston, we're seeing the Steward hospitals, which were a system of hospitals, have filed for bankruptcy. There's all kinds of shady things going on there. But because there are limited budgets in hospitals right now, do you feel that as an educator, you could benefit from more money coming into your end for nursing education, just for educational tools, or I don't know, just more things at your disposal to help nurses and to help education? Is that something you wish to kind of put more money aside for you?
Yes, definitely. It's hard to have 130 nurses as for one person. So if there were more resources available, or even, innovation is the big thing in nursing right now. And a lot of the things that are innovative in how to train new people are things that we don't have the budget for. Even like different online programs, games, things you can do for anybody that's new. We just don't have the budget to provide that to every new nurse. And so I wish we had that.
Yeah. And I mean, to add a little context to that too. So Boston Medical Center, it's in South Boston. Like I said, it's a level one trauma center, but it serves a really underserved population. I think somebody once told me that it's responsible for 70% of all the free healthcare in the entire state of Massachusetts, not just in Boston, but not just Massachusetts, but in Boston. Excuse me. So 70% of all the free healthcare in Massachusetts takes place at our one hospital. So a lot of that is subsidized by the government. When you have that going on, you don't have a lot of leftover money just to kind of spend on some of the little things that might be a little bit more helpful for a nursing standpoint anyway. Uh, Once again, kind of coming back to the pandemic, because it did take such a toll, not only kind of financially on healthcare institutions, but on the nursing profession in and of itself. There were so many nurses that did leave the profession. Uh, According to the National Council of State Boards of Nursing, there were, and I'm quoting, approximately 100,000 registered nurses left the workforce during COVID-19. This was due to stress, burnout, and retirements. And then another 610,388 RNs reported the intent to leave by 2027 due to the same factors, the stress, the burnout, and retirement. So in all, you're talking about almost, three-quarters of a million nurses that have left the workforce due to this. And you and I can both attest to this. We saw a lot of turnover before and after COVID on our units. How much stress does this put on you with having, we have to fill all those roles, all those nurses that left? Somebody has to come in and take their positions. So probably a lot of new hires, a lot of new grads. How much stress does that put on you over the last couple of years, just with regard to educating all these people?
How much stress? A lot of stress. It's the thing that is most stressful in my opinion is that you don't have experienced nurses training new nurses anymore, and that's really stressful because I always say you have baby nurses training baby nurses, or baby ICU nurses training baby ICU nurses. And nursing and healthcare in general has changed so much since the start of COVID. Nursing programs run, everything about how nursing is has changed. And before, you had experience training people, so there were like certain things that got done because this is how this is what we do. People get turned every 2 hours because this is what we do. Everybody goes around in a circle and turns every patient every 2 hours. And that's fantastic, but that's not how people get trained anymore. And a lot of things changed during COVID, what kind of meds we use, how much medication we use, different policies. And with all of that change, it's just totally changed how nursing is. So I think it's been really difficult to have so much turnover because you're training somebody and they're fantastic, but they're only staying for maybe a year. And on top of that, you have people that are brand new ICU nurses since COVID that can't really speak to what the culture was like before COVID. And the culture has changed so tremendously that when you tell people, just 5 short years ago, this is what we used to do, nurses are like, no, no way. It's like when you tell people, when I first started as a nurse, I documented on paper. No one believes it. But that's exactly how it's been since COVID. There's BC before COVID, and there's after COVID. And it's just two totally different worlds that if you didn't experience it before, you have no idea what kind of things you're missing out on.
So it kind of a related question to that. So with COVID, a lot of in-person education was taken away. So nursing students, they could still come when I was working there, would still have nursing students, but a lot of them weren't allowed to enter COVID rooms. There was just a
Mm.
lot less hands-on training that they'd get. A lot of them didn't have classes in person, so it was a lot of kind of distance learning. And I'm just wondering if you've seen a difference, in the last 2 or 3 years, all that's resumed. So there's the in-class training, our students can do more. But the couple of years, 2020, 2021 even, nursing students that you're seeing are new grads, I should say, that were kind of in nursing school during then. Have you noticed any kind of a difference? I'm not trying to, say that or have you throw any, particular class under the bus or not. But those classes that graduated then, do you feel they were a little more hard or a little more difficult to educate with regard to certain aspects because they just didn't have the experience that they should have had in school at the bedside or treating patients or from distance learning?
Oh my gosh. Even it's like the physical skills, like you mentioned, they weren't taking care, they weren't touching real patients. It was all virtual or through simulation. And so just like the hands-on, it's that's been really difficult. And by hands-on, I mean, how do you turn a patient when there's just two of you and this patient is, you really need four people to turn? How do you like proper body mechanics? I can't even tell you with my nursing students how much I have to teach proper body mechanics. But also, I think a huge piece that's missing is that social interaction and picking up on social cues. The students that had the distance learning, that had the like simulations, they might be like great nurses, but they're the social cues of like how like assessing patients when someone's in pain, they didn't get that. So when someone's grimacing, you and I might be like, oh, they're grimacing, they're in pain. But for some of these new grads, they only ever saw that virtually. So they don't pick up on those cues as easily, which I think is a little detrimental to the profession because so much of what we do is hands-on and talking to our patients and getting to know them. And by the second day, when they make this face, they're in pain and they need pain medication. It's just different now.
Yeah, it's those little things, and that's something that hopefully, it comes with experience too. That
Yeah.
with newer nurses, the more they kind of are exposed to that, they'll
Yeah.
pick up on those things. Kind of going down the same road as we talked about before with just new influx of new grad nurses. Uh, we're still kind of experiencing a nursing shortage. We have for a while. Obviously, with COVID, we lost a lot more, and this, shortage, it's supposed to continue for the next 10 to 15 years. Baby boomers are retiring, they're getting older. People are just more unhealthy, they're worse off. And per the US Bureau of Labor and Statistics, they project that more than 275,000 additional nurses will be needed over the course of the next 10 years, and that employment opportunities for nurses will actually grow by 9%, which is faster than any other occupation through 2026. So with that, we have a nursing deficit right now anyway, hiring all these new grads. We're going to need even more new grads to come in. Do you feel that nursing units and hospitals will actually have enough educator roles to appropriately educate all these new grads that come in? Do you feel that at some point in time there may be more than one educator on our unit or any given unit, depending on the amount of nurses that they have?
I would love to say yes, there have to be more educators, but I don't think there's going to be. I think aside from budgetary restrictions, just the people I see that want to leave the bedside, people don't want to go into this educational aspect of it. I have one very good friend that works in academia. She's a nursing professor, and she's even in academia, there's far less nurse educators than there used to be. It's difficult to get nurse educators. There's shortages like at the nursing schools themselves for educators, and then at the bedside, I think I I don't know a ton of people that are looking to go into get their master's for education. they're looking to go, if they're going to go for more schooling, it's to go into some other kind of nursing. So I think the shortage is going to continue, unfortunately.
It's going to be interesting to see how it shakes out, especially with long-term care facilities, nursing homes. They're just going to become overloaded, and those patients are going to decompensate. They're going to send to the hospitals. The hospitals are going to get overloaded. It's kind of scary when you think about it.
Hmm.
Um, so as far as nurses go, so in the ICU, obviously, it's a very complicated, very stressful environment. Regardless of the experience level, has it been harder to educate, or I shouldn't even say regardless, I should say due to experience level? Do you feel that nurses who have been there for a long time are harder to get to conform to new policies than your new grads? Just because as old nurses, we have old habits, we hate change. It's hard to break habits, good or bad. Uh, and I would feel that, and you can maybe attest to this, I would feel like as a new grad, like new grads, you can kind of help to mold and condition them to follow policies the way they're supposed to be followed.
I it's interesting you ask that because I think that I'm very fortunate. I tell people all the time how fortunate I am in my unit because there are seasoned nurses, but because I have the relationship with them, like I mentioned before, that from my unit, I don't feel like I get pushback because the nurses that, and there have been nurses that definitely, give pushback on new things, but the follow through, my follow up and the follow through with them has helped make our relationship better. And so when something new comes out, there's always like a little grumbling here and there, but I think for the most part, people understand. And I think I've done a lot in my unit to promote evidence-based practice. I think people know I'm a policy person. I like evidence-based practice. So when they hear me talking about something new, but aside from the initial grumblings, they're usually okay with it. But I can't say it's like that everywhere else. I don't know. I can't speak to other areas of hospital, med surge, ED, any of that. But I think
Yeah.
in my medical ICU, I feel very lucky.
Well, we're lucky to have you, and that's one of the reasons why I said, you're the best educator that I've had, just because you do like it's not just to do this because I told you to do it. We're going to do this, and this is why. So just providing explanation for it, providing the evidence for it, it makes sense. So that's something that I've come to appreciate very much.
Thanks.
Uh, with regard to educating, so artificial intelligence, kind of a hot topic. It's something that is becoming more and more prevalent and will continue to become more prevalent, over the next 5 to 10 years, maybe even sooner than that. The American Nursing Association, they do have a statement regarding AI. I'm going to read their statement right now. It's a little bit wordy, so bear with me. So, with regard to artificial intelligence, the American Nursing Association says, quote, nursing values and ethics described in the Code of Ethics for Nurses with interpretive statements place caring and compassion as central elements in the nurse-patient relationship. The American Nursing Association believes the appropriate use of AI in nursing practice supports and enhances the core values and ethical obligations of the profession. AI that appears to impede or diminish these core values and obligations must be avoided or incorporated only in such ways that these values and obligations are protected. Nurses must ensure that advanced technologies do not compromise the nature of human interactions and relationships central to the nursing profession. It is crucial that nurses anticipate and evaluate the impact of AI on healthcare through a proactive approach that emphasizes agency, caring, and influence over how technology is developed and applied. It also says nurses must be informed about AI so they can provide appropriate education to patients and families to dispel myths and alleviate fears, thereby support the use of AI for optimal growth and health outcomes. With that being said, can you see AI being incorporated, from a nursing educator standpoint, at any point in time in the near future? Do you know of any studies, or do you have any plans to actually incorporate AI into your practice?
That's so within the practice at the hospital, they are talking about getting AI and getting like cameras almost that are so nurses are watching patients from afar and then kind of dialing in and saying, can someone go into, room 25 and take care of this patient and do something for this patient? I think that's definitely big in healthcare right now. There seems to be a push for it. But my own perspective on this, I tell my new grads all the time. I'm like, you know what? You can teach a 5-year-old to do half the skills you guys do. I'm not worried about you guys developing your hands on skills. What I can't teach people is how to be compassionate, how to be kind. I cannot teach you how to critically think. I cannot teach 5-year-olds how to critically think that well. That is really like, to me, that's the heart of a nurse. It's not any of those like hands on physical skills. It's really about the caring aspect. So I worry that with AI, it's going to take some of that away. And that's why I think with my nurses, my new nurses, I really emphasize that point. So anybody can do this job. If you're not here, someone else can do it. But are you caring? Are you kind? Those nurses I can work with.
And yeah, I have to agree. I think that's, like you said, at the heart of nursing, it's the human aspect of it, having the
Mhm.
feelings, the empathy, sympathy,
Yeah.
being able to feel for somebody, just being there for somebody else too, just even, just touch, like having, putting your hand on somebody's shoulder, holding their hand while they're in pain. That's
Mhm.
something that AI can't do. I actually think AI could be really important, especially diagnostically. There's actually it could be really important as far as excuse me, MDROs, so drug-resistant organisms. There are certain AI algorithms that are able to work to find appropriate antibiotics faster for these organisms, these infections. And there's other aspects of AI for diagnostics that actually seems like it's really promising, but that's more on the, physician side of things, not something that nurses, I don't think that the nursing role will ever be taken away by AI, even though there's probably aspects of AI that could definitely help. So,
I agree.
yeah. So I guess I'll kind of finish up with the last question I have for you is just how do you feel that the role of a nursing educator will actually change over the next, 10, 20, 30 years? Do you feel that at any point in time that the role, I mean, it'll never become obsolete, it'll never become extinct because there's always going to be new nurses to teach. Do you feel that it will become more, I don't know, I wouldn't say more hands-on because you're very hands-on anyway, but like I said, with these new technologies we're integrating, will there be less educating face to face from your aspect and more kind of having more AI or computer based education, and you're there to make sure people are doing things right? What are your thoughts on that?
I think that's probably true. I think there's probably going to be a push to do more things virtually. Even things like QR codes are put on all sorts of devices now so that you, in the moment, can scan a QR code and learn how to use a device. So I think that's going to definitely take some pieces of my job away because I won't be teaching somebody how to set something up because AI will do that or scanning something will do that. But I don't think my job will be obsolete. And I think that hopefully I'm still needed, if for nothing else, to teach people how to have like those kind, compassionate, empathetic pieces of being a nurse and making sure people are following through because ultimately, I can train somebody to do things the right way, but unless they're following through with it, like that can come back on me. If somebody's not trained the right way, they can come back and point their fingers and say, "Well, Allison didn't do her job." So, I still have to be there and making sure people are doing the right things.
And I guess I said that was the last question, but one more. So I have a niece who will be entering nursing school this fall at Emmanuel College here in Boston. So
Nice.
if you had any words of advice for her throughout her nursing schooling, what's the best advice? Like, do you have any one thing that you might notice or that you see more than others out of new grads that you wish they would have concentrated on more in nursing school? Or do you feel that when they come out, they're kind of, all just this moldable ball of clay that, just needs tweaking?
Um, I have kind of two things, I guess. One, take every single opportunity to learn any chance you can. If she can get a job working as like a nursing assistant anywhere, I think that has been huge, especially in post-COVID, to be in an acute setting as early as they can. I think that, but also just, I do this with my nursing students all the time. By the time they get to me, they're seniors, and I say, like, I just want you to talk to the patients and just, hold their hand, notice them for who they are. Is this patient somebody that has a beard all the time, or is this someone that has, they have 10 days worth of growth because they've been in the hospital for 10 days? Look at them as a person holistically and take care of them as a person. So it should always be about the patient first.
Excellent. Well, thank you so much. Thank you for coming on. Thank you again just for kind of sharing what the nursing educator role is, because like I said, I don't think people even know that there is that role outside of healthcare. So if you work in healthcare or on a unit, you're probably aware of it. But if you were to go and ask people on the street, they might not have any idea. So I think it's an important role. I appreciate everything you do. You do a fantastic job.
Thanks.
And Yeah, thank you for coming on. And like I said, hopefully, people will listen to this and could even maybe encourage people who weren't thinking about going into nursing to go down that road, because there are so many avenues once you enter nursing, that even if you aren't compelled to be at the bedside, that you can also, you can still do education. There's just so many other aspects that if you become disillusioned with the bedside stuff, that you can go towards. So, Allison, thank you very much.
Thank you, Andy. I appreciate you having me.
Yes, I will see you at work. All right.
All right. See you.
Take care.
You too. Bye.
Bye.
Late at night, in a classroom dim, nursing educators, they begin sharing knowledge with hearts so bright, guiding us through the darkest night. They're the keepers of wisdom light, teaching us, preparing us for the fight. From the basics to the latest trends, they're the ones we cannot comprehend. In the clinic, the hospital halls, nursing educators answer calls, training new nurses, their passion unveiling, bridging the gap, the knowledge revealing. In the clinic, the hospital halls, nursing educators answer calls, training new nurses, their passion unyielding, bridging the gap, the knowledge revealed.